कि अल्लाह ताला के पाक नाम से आज के इस वेबिनार का आगाज करें सर।
औज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम, खतमल्लाहु अला कुलूबिहिम व अला समइहिम व अला अबसारिहिम गिशावा वअला अबसारिहिम गिशावतुम वलहुम अज़ाबुन अज़ीम। तर्जुमा, खुदा ने उनके दिलों और कानों पर मोहर लगा रखी है और उनकी आंखों पर पर्दा पड़ा हुआ है और उनके लिए बड़ा अजाब तैयार है। सदक़ल्लाहुल अज़ीम।
जी, इससे पेशतर कि मैं अपने स्पीकर्स का तारुफ कराऊं। आज हमारे एक हीरो की डेथ है हुई है, अल्लाह की रहमत में चले गए हमारे हीरो पाकिस्तान के, जिनकी वजह से आज पाकिस्तान अपने आप का सर फ़ख्र से बुलंद कर सकता है पूरी दुनिया के अंदर, जिन्होंने हमने न्यूक्लियर पावर, ना सिर्फ न्यूक्लियर पावर और न्यूक्लियर मेडिसिन का जिन्होंने आगाज़ किया। तो मैं रिक्वेस्ट करूँगा प्रोफेसर राशिद साहब के उनके लिए फातिहा खानी भी करवा दें सर।
औज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम, अल्हम्दुलिल्लाहि रब्बिल आलमीन, अर्रहमानिर रहीम, मालिकि यौमिद्दीन, इय्याका नअबुदु व इय्याका नस्तईन, इहदिनस सिरातल मुस्तक़ीम, सिरातल लज़ीना अनअमता अलैहिम, गैरिल मग़दूबि अलैहिम वलद्दालीन, आमीन। बिस्मिल्लाहिर रहमानिर रहीम, कुल हुवल्लाहु अहद, अल्लाहु समद, लम यलिद व लम यूलद व लम यकुल लहू कुफुवन अहद। कुल हुवल्लाहु अहद, अल्लाहु समद, लम यलिद व लम यूलद व लम यकुल लहू कुफुवन अहद। कुल हुवल्लाहु अहद, अल्लाहु समद, लम यलिद व लम यूलद व लम यकुल लहू कुफुवन अहद। या अल्लाह ताला, जो अल्लाह ताला हमने इस कुरान पाक की तिलावत फरमाई, इसका सवाब मरहूम डॉक्टर अब्दुल कबीर साहब की रूह को बख्श दे। या अल्लाह उनकी बख्शिश फरमा, उनके दर्जात बुलंद अता फरमा, उनके लवाहिकीन को सब्र अता फरमा, उन्हें जन्नतुल फिरदौस में अता फरमा, उन्हें अपने बाला तरीन मकाम अता फरमा। सल्लल्लाहु तआला अला खैर खल्क़ि मुहम्मद व आलिहि व अस्हाबिहि अजमईन बिरहमतिका या अरहमर राहिमीन।
आज के हमारे लेजेंड स्पीकर प्रोफेसर फ़ारूक गनी हैं और उनके साथ हमारे पैनलिस्ट प्रोफेसर आमिर एजाज साहब हैं। दोनों हमारे केमिकल पैथोलॉजी के लेजेंड हैं। तो प्रोफेसर फ़ारूक गनी जो हैं डिड द MBBS फ्रॉम कराची, followed by the training at pathology at Boston University Medical Center, United States of America. He did his fellowship in the pathology and laboratory medicine in Boston. He also received his PhD in pathology from Boston University, and he is also certified by the American Board of Chemical Pathology. Dr. Ghani has held faculty and the consultant position at Hartford University, Connecticut, New York Medical College, at Westchester Medical Center, New York, and has director as the Bayer Healthcare in the New York. Dr. Ghani held the first successful College American CAP accreditation lab in the Pakistan. Currently, Professor Ghani is leading laboratory in Aga Khan Medical University. And Professor Ghani, Dr. Ghani is not only a pathologist, chemical pathologist, he is a legend teacher and academician. And I remember I cannot countless seminars with Dr. Ghani in all over the world. Professor Aamir Ejaz is the writer of many books, and Brigadier Aamir, we are proud of his efforts. हम अक्सर सुना करते हैं मैडम कि लेबॉर्ट्री की क्वालिटी कंट्रोल के अंदर इन दोनों शख्सियात के जो किरदार है, आई डू नॉट थिंक कि अगर मैं इनको मनफी कर दूं तो हमारे पैथोलॉजी का वो हिस्सा अक्सर वो ब्लैंक हो जाएगा. We are proud of these two personality and few others of the chemical pathology people along with him, कि उन्होंने क्वालिटी कंट्रोल के ऊपर बहुत सर्विसेज की. और इंशाल्लाह ताला डॉक्टर आमिर के साथ और डॉक्टर फरूक गनी के साथ हमने इस तरह के और भी आज कार्डियक मार्कर के ऊपर मैंने रिक्वेस्ट की थी. वेरी वेरी इंपॉर्टेंट टॉपिक, बिकॉज वन ऑफ द मोस्ट commonest cause all over the world is the heart attack, and it is very difficult when the heart attack to diagnose. Sometime 45% of the cases are missed due to the misdiagnosis. Inshallah, today's cardiac month on this lecture, we will be able to understand the myocardial infarction in its test. Dr. Farooq Ghani, now it is over to you.
Thank you, Dr. Mulazim Bukhari, for I'm humbled by the invitation and by your very generous introduction. I would like to thank Professor Salma Kundi, Professor Mulazim Bukhari for arranging and inviting me here. It's a pleasure to be with Brigadier Aamir Ejaz, my longtime colleague in pathology, and who Dr. Aamir Ejaz has also had a very long and distinguished career in academic and is a very committed academician, in academics and also in teaching and research. With Dr. Mulazim and I consider him a friend and a colleague for. We've been together, as he said, and have joined hands in organizing academic activities at national and international level within the country. And I have known him, and we have followed each other since he was at KE. And I think, I'm very, very happy and glad to see that a person like him is now heading the Pakistan Association of Pathologists, and I think the pathology fraternity at large would greatly benefit from this, from his appointment. So congratulations, Dr. Mulazim, once again, and thank you, everyone. So I'm going to talk about heart disease and cardiac markers. Cardiac markers are amongst some of the other areas of my interest in my career. So I've had my long career, more than 18 years in US, and now I've been associated with Aga Khan University, and we were able to get the CAP accreditation. But also we've been able to continue with some of the research that I was involved with. And one of the areas was the markers, the biochemical markers for cardiovascular diseases. And I've had the privilege of working with some of the very distinguished people who have written the guidelines, and as we go along, I will try to explain what are the new direction in which this field is moving, and we'll try to make it as simple as possible. And at the end of it, I would welcome any comments and questions. Okay, so as Professor Mulazim said, that it is a leading cause of death worldwide. The incidence of myocardial infarction is now we see this in more and more in younger people, and almost half of the population that has MI are below 60 or 65 years of age. And the mortality still remains very high. And I'm giving you the mortality numbers in the West. We don't have any national numbers, but I would think that our numbers would be quite high. So one of the problems is that patients with myocardial infarction are mistakenly discharged from the emergency department. And this is, some of the studies that were done in the US, and there about, roughly about 5% of patients are discharged who have diagnosis. I would suspect that it is much higher. And I think, as Dr. Mulazim said, there is probably in the vicinity of between 40 and 50% here, which is very, very alarming. And many of them end up dying, the ones who are wrongly discharged. Now, lack of knowledge or lack of information is really a double-edged sword. So what we're doing, we are not only discharging patients from the emergency department who had myocardial infarction, who should not have been discharged. Our health systems in general admit patients who do not have heart disease or myocardial infarction. So if 100 patients present to an ER with chest pain, only about 13 to 15% of them really have myocardial infarction. The vast majority of them do not. And the irony is that 60% of them end up getting admitted for no reason. So it is not only a burden on the healthcare system, but it is really, ethically and medically a wrong practice. So if you look at the progression of the disease, and this is for some of the junior people on the forum, so it starts with the foam cells, and we're all going back to our physiology days, and then the fatty streak, then the intermediate lesion. This is the development of atherosclerosis, and then the atheroma. Then you have the fibrous plaque, and then it ruptures and causes occlusion, which leads to heart attack. So okay. So we have a battery of markers for cardiovascular diseases, right from the risk, for instance, homocysteine, CRP, and oxidized LDL. These are three very good candidates for determining patients at high risk. In addition to the normal lipid profile. For thrombosis, D-dimer and homocysteine are good markers. Once you have an event, once a patient has an event that is a myocardial injury, then of course troponin is by far the best and the only marker that should be used. Once the heart is damaged, then it might lead to heart failure, and BNP or NT-proBNP is the marker that should be utilized for patient management. So, and so for time constraints, I would only concentrate on these two markers, troponin and BNP. So early detection of myocardial infarction. Now troponin, there's a lot of buzz about high sensitivity troponin. And this is, Dr. Mulazim asked me to talk about that, and which is a very pertinent subject. We have also transitioned now from a regular troponin assay to high sensitivity. And there are pros and cons for this. And I think the cons are, I think that it is there is really no cons. There are cons if people are not informed and not using it properly. And that is why Europe has been using it now for almost 10 years. US only recently, once the data emerged and once people now know how to utilize it, that the health system in the US have now shifted toward the high sensitivity. So this is the article that was published, and this is the guidelines by the AACC and IFCC. This is Alan Wu is the primary author. Alan and I have, I've had the privilege of working with Alan in Hartford for several years, and we've worked on cardiac markers and published many papers, and I will talk about it. So high sensitivity troponin assay. So why do we call it high sensitivity? We call it high sensitivity because now, instead of the 90th or the 95th percentile, we are using the 99th percentile of an upper reference limit. And not only that, the assay has to be robust. That is, the CV, that is coefficient of variance, should be less than 10%. In simple words, that the assay should be very reproducible, and the variation should not be more than 10% if you are to do a repeated testing on it. So not only that, but what they have, so LOD is limit of detection. So 50% of the healthy population should be above the limit of detection, but below the cutoff. So these are quite stringent measures that were proposed, and the companies went to the drawing boards and have come up with the assays, which are now very robust and are being widely used. So the reporting units, they used to be in decimals. Now it is in whole numbers. And that is really, I've been advocating that, and many others for a long time, that we should really be using whole numbers. When you talk about, 0.03, 0.12, or 0.4, that somehow doesn't have the same connotation as numbers. So, for instance, first we used to say 0.014 nanograms per liter, but micrograms per liter. And now we've changed the units and we call it 14 nanograms per liter. Okay, so it is the same thing. But just that we are using, so you have to be very careful. And I think people get a little frazzled when they're used to these very small numbers for troponin, and now they see a very high number and they think that there's something terribly wrong with the patient. So it is very important for the lab and the pathology fraternity to make sure that this message is propagated and gets across to the ED physicians and the cardiologists. So quality control, this is for my pathology colleagues, that you should be doing 3 different concentrations of QC at least once per day. So we are using Siemens assay for high sensitivity, and we're very happy with that. And it uses, like many other assays, have 2 cutoffs. Female tend to have a little lower value than male, and this is very important. Before we had just 1 cutoff, now we have 2 cutoffs. So one needs to be very cognizant of that. So criteria for myocardial injury. The term myocardial injury should be used when there is evidence of elevated cardiac troponin values with at least 1 value above the cutoff. So you need to have at least 1 value above the cutoff. And we will come to what are the algorithms that should be used. The myocardial injury is considered acute if there is a rise or fall of troponin value. So I think, so there are 2 things now to remember. One, that you should have at least 1 value that is higher than the cutoff. And the second, that you should be able to demonstrate a rise or a fall. Only then you can say that this is an acute condition. If you really see the flat same value, then it is not an acute injury. Now, so troponin, we used to think that it is only raised in myocardial infarction, and only if you have a massive heart attack, your troponin is raised. And every time the troponin was raised, there was bell alarms were sound, and it was automatically assumed that a patient is undergoing myocardial infarction, which is not the case. And now, especially with the high sensitivity, because a lot of diseases now have raised, and I will come, and it's a very exhaustive list. You've all gone through COVID, and we know that we've had myocardial injury, myocarditis in many COVID patients, and you would see increase in troponins. But I think, by the end of this talk, I hope that you'd be able to appreciate that, what is the increase that you see in other diseases, and what is the difference between the increase that you see in myocardial infarction. I think that is really the crux of the matter. So, sorry, I cannot see the top of this. So if you have myocardial, if you have acute myocardial injury or AMI, then you will, as I said, you would see a raise in the values, and you should be able to see either a rise or fall. Now, myocardial injury can also be by many other causes, and what we call a mismatch. Mismatch means that there is some supply and demand issues. What does that mean? Means that either the blood isn't being supplied properly to the heart, or the demand to supply oxygen is increased. For instance, reduced myocardial perfusion, there's a long list, for instance, respiratory failure, even severe anemia, which is not uncommon in this part of the world. Increased oxygen demand, for instance, in severe hypertension or sustained tachyarrhythmias can cause increased demand. Other causes for myocardial injury, heart failure, myocarditis, as I mentioned, catheter ablation, defibrillation. This is important. So as you can see, this is a very exhaustive list. Systemic condition, and this is very important, and we should be cognizant that a lot of patients who have sepsis will have increase in their troponins. But if there's no overt damage to the heart, you will not see a rise or a fall in the level, or the levels of the increase will not be very high. Chronic kidney disease, you see elevated troponins and stroke. Patients who are undergoing chemotherapy, a lot of these chemotherapeutic agents are cardiotoxic. Many patients in ICU, we see they have some level of troponins. So we'll try to simplify this, and this is a busy slide. Let me just walk you through it, and hopefully we'll simplify. So there are three things. We've talked about myocardial infarction. For simplicity, I will just talk about type 1 and type 2. Myocardial lesions, as we talked, this does not include infarction. And there's a long list, and I've just shown you that. And then there's a chronic increase, meaning that you would see a sustained level. You would not see an increase or decrease. Sometimes you see this in patients who have uncontrolled diabetes or renal insufficiency, cardiomyopathies, or cardiac insufficiencies. So these are chronic conditions, and so these patients should not be rushed to the cath lab or into any interventions. This, however, is a very different story. So the aim is to really be able to use the troponin to be able to differentiate between the chronic cases, other causes of myocardial injury, and the actual ischemic myocardial infarction. So type 1 is directly complicated by atheromatous plaque rupture. So that is, if there's a plaque rupture, we call it a type 1. Type 2 is the mismatch, which I just talked about, that either there's an increased supply or demand. Okay, there is no atherosclerosis or rupture here. You would still have some level of, and these are some of the conditions that we've already talked about. So what is the criteria for AMI? Clinical evidence of acute myocardial ischemia, you should be able to see there should be a clinical evidence of ischemia. Okay. And with the detection of a rise and fall of troponin values, I've already mentioned that too. And third is that at least one value should be above the cutoff. And one of the following. So the patient should either have symptoms of ischemia. So if a patient has symptoms, has troponin, high levels of troponin, very likelihood that this is a myocardial infarction. If there's a rise or fall, it is an acute myocardial infarction. If you see new ischemic changes in the ECG. If on imaging, you see loss of viable myocardium, could be echo or other sources. Or if there's evidence of an imbalance between myocardial oxygen supply and demand. And this, of course, this will be type 2. Okay. So as you remember, type 1 is because of atherosclerosis and thrombosis, and type 2 is because of the imbalance or mismatch of supply and demand. Myocardial injury in critically ill patients. So elevation of troponin values are not common in patients with intensive care units. I've already mentioned that. Okay. And they will have an adverse prognosis regardless of the underlying state. So it is very challenging for the clinicians caring for the critically ill patients with severe single organ or multi-organ pathological condition to decide on a plan of action when the patient has elevated troponin values. Basically, that when do they really intervene and do something about the heart. So the patient has a lot of other problems, critically ill. In addition, the troponin is increased. You know, whether you address it, how do you address it? And that is a very critical question. And the advice by the cardiologist is that, you know, we don't delay this. We don't delay the investigation and the decision making. Even if the patient is critically ill, if we think that there is the myocardial injury is substantial and the intervention is required, then it should not be delayed. If and when the patient recovers from the critical illness, clinical judgment should be applied to decide whether and to what extent further evaluation is indicated. So I think, you know, that is very critical, that not to wait for too long before you do the intervention if and when it is required. So I think this slide will help you clarify what I'm saying. So when I said AMI, so this is your cutoff. So here's the level of troponin in acute in AMI. And as you can see that it rises, reaches the peak, and it falls off. So if you were to measure at any 2 points, say for instance, if you measured here and here, you would see a very marked difference. You would see a rise. If you measure here and here, you would see a fall. So you know this is an acute event. Whereas chronic myocardial injury, as I said, with many patients with renal disease or respiratory disorders or other severe conditions, their troponin values would be flat. or very little change. And we'll talk about what is the level of change that is significant. So change in the level, that is all the delta means change in level. So for instance, if you did troponin twice, what is the difference of troponin between the first measurement and the second measurement? So here's an important piece of information. So if we are talking about levels that are below the cutoff, then a change has to be more than 50% for it to be significant. Okay. However, if you're talking about two measurements and both are above the cutoff, then recommendation says that even if there's a change of more than 20%, it should be considered as a delta or a significant change. Now, speaking to cardiologists in the US, the rule of thumb that they use is the doubling rule. That if there is a doubling of troponin values, once it is elevated, it is, they consider it significant. But nevertheless, the data says that even 20% is quite significant. So as I said, the European Society of Cardiology, ESC, came up with guidelines in 2015. I won't go much into it, but just some salient features. So we've talked about rule in and rule out. So, it is not a black and white now, as it is probably apparent now from my talk so far, that rule out means that a patient comes in, you do the testing, you rule out, you send the patient home. Rule in meaning that yes, the patient has myocardial injury or myocardial infarction, and then the patient is disbursed to the cath lab. So there needs to be at least two measurements, and a large number of these patients would require a second troponin test. Okay, so we have now shrinked this time to 3 hours. Now, if you remember, the old guidelines talked about 12 hours. We used to hold patients for 12 hours. When I was in training, we used to do that for 12 hours in the US. Then we brought it down to 9 hours, that you have to hold patients with chest pain for 9 hours, do serial testing. Then it became 6 hours, and now it's 3 hours. And now there are even protocols for 0 and 1 hour. And I think, this shrinkage is very important, because it is extremely important to do a rapid diagnosis, not only because, not to occupy the emergency beds, but also to do timely interventions. So if there's a high degree of clinical suspicion of non-ST elevated acute coronary syndrome, then you should go for coronary angiography. If there's a low or intermediate likelihood of ACS, then the guidelines suggest a CT angiogram. Okay, so angiography for high risk, a CT angiogram for an intermediate risk. This is a very important slide, and let me walk you through this. And if anybody has any problem following it, I'll try to simplify this. If I can get hold of this mouse. Okay, so a patient presents with acute chest pain. Okay, it's two scenarios, either troponin negative, troponin positive. Okay, so if the troponin is negative, and the patient has had pain for more than 6 hours. So in other words, that, agar badhna tha to ab tak badh gaya hota, so you've given 6 hours and there's still no troponin increased, and the patient is not high risk. And GRACE is a score which takes into account 8 different parameters. Blood pressure, age, things like that. And and you can put it and get it is quite easy to do, and it is commonly done in the emergency rooms. So if the patient is low risk, then the patient should be discharged. Okay, so simple. So only one measurement, greater than 6 hours, low risk, you can discharge, or you can send for stress testing if there's any doubt. If it has been less than 6 hours, then you retest after 3 hours. So this is a 0-3 algorithm. Okay, so the first one was negative. The patient has not had pain for more than 6 hours. The second was done at 3 hours. There's no change. That is, it is not increased again. Low risk, patient can be discharged. Very simple. Now, if the troponin is high, patient had a chest pain, you're in the emergency department, patient comes in, you order troponin, troponins are elevated at 0 time. Okay. If the troponin values are very high and there's a very strong clinical presentation, or there is evidence in the ECG or abnormal wall motion defect, then you do invasive management. You don't even wait for 3 hours sample. So that is the purpose of this fast tracking this. However, if there's only a slight raise of troponin, then remember, then it could be a lot of other conditions that are not AMI. So you want to wait for 3 hours and you want to retest the troponin. If there is a change, and we've talked about the change, generally doubling. If you see a change in troponin, it means it is an acute event. It is an acute myocardial infarction. You send the patient to the cath lab for invasive management, or whatever that case might be. I'm saying cath lab because that's the most common outcome. So troponin is elevated, you retest it, no change. This is a little, so you have to work up for differential diagnosis. Now, all the list that I showed you earlier, that is all up for grabs now. Now you need to really, this becomes, now your ED physician now starts scratching his head now over to what to do next. So I think I will skip this because I'm not talking about other markers, but I'll just mention them in passing. So cholesterol, hs-CRP, oxidized LDL, these are markers for risk. There's a marker, myeloperoxidase, for plaque rupture. I will talk about it just very briefly. Modified albumin is a good marker for ischemia, but it is still work in progress. This has not made it to the prime time yet. Necrosis, troponin, high sensitivity troponin, hands down, excuse me, the best and the only marker. And then the chronic heart failure is BNP. So this is very important to remember that most of the infarction that we see is seen in patients who have less than 50% stenosis. So 2/3 of your MIs, and we the general public and even the medical community is so fixated with the percent of blockage. Itni percent iski blockage hai, iski 20 hai, to iski 50 hai, iski 90, and we think that that is all that matters. Really not. It is not the degree of stenosis. It is what is the plaque? What is the nature of the plaque? Is it a stable or an unstable plaque that is prone to rupture? Okay, so that is really a very important thing to remember. So here is the early plaque. So there are two. If you're lucky, you get a good fibrous cap, and you have a good lumen, and the chances are that this will not burst and this will not cause thrombus. However, if the fibrous cap is thin and you have a lot of inflammatory changes going on, and you have a molecule called phospholipase, then it is likely to rupture. So I'm just going to do a passing mention here, but phospholipase, and you might hear about the marker a lot in the coming years. It is now emerging as the marker. It is secreted by macrophages, and it triggers a cascade of events that causes thrombus formation. And you can measure these in the blood, and there are a lot of studies now that have shown that if there's elevation of phospholipase is associated with poor outcome. So if you know a patient who has atherosclerosis, now you can find out if that plaque is going to rupture or not. So this would be a wonderful tool once it is made available. So I've come to the last part of my talk of heart failure. So heart is basically, excuse me, heart is basically a pump. And once you have a damage to the myocardium, it will not pump the blood in the body. So you will not, a lot of the vital organs will not get the required perfusion, and you will have an overload. So it is really a clinical term. And now that we have made a lot of headway in treating patients with myocardial infarction, एक वक्त वो था कि लोग heart attack होता था तो they wouldn't survive. Now with this new techniques and new methodologies we have, a lot of people with heart attack are now surviving. So now we are giving rise to a generation of people who have injured myocardium and have heart failure. And heart failure is a debilitating condition if not treated properly. And they're very non-specific signs and symptoms. So it has a very high symptom. It is one of the leading cause of hospitalization in the elderly, high mortality. So it's a situation when the heart is incapable of maintaining a cardiac output. It is adequate to accommodate metabolic requirements and venous return. So the common symptoms are dyspnea, edema, and fatigue. Now this is, a patient walks into the ER, has, difficulty breathing, has swelling. The question is whether this is because of the heart, or is it because of the lung, or because of the kidney. So New York heart failure has classified from class 1 to 4 based on New York Heart Association guideline, 1 being the least and 4 being the most severe. And obviously the mortality is much higher with the increasing of the classes. So, so basically, I'm just going to very briefly. So, pro-BNP is present in myocardium. Once the myocardium is stretched and is under duress, it releases pro-BNP, which is uncleaved into anti-pro-BNP and PNP. And we measure mostly anti-pro-BNP because it has a longer half-life. So when I say BNP, it could be either or. Sorry, I can't seem to move the slide. Okay. Oh. Let's see where I was. I've hidden most of the slides. Okay. So breathing not proper study. Now this was a study that I was, and along with Alan Wu, who I mentioned, who's written the guidelines. Alan and I had worked at Hartford Hospital for several years. So this study, Alan and I were the PI of this study. This was a multi-center study, 6 centers in the US, 2 in Europe. And we published this in Clinical Chemistry. This was the first assay that was developed, and I got the FDA approval for Bayer Healthcare, where I was working as a medical director at the time. So that study showed that BNP levels increases with age. This is healthy population, and you can see that BNP levels increase, and once you pass 70, there's a sharp rise. Therefore, we have 2 cutoffs for BNP, one for below 70 and one for above 70. So that is important to remember. And the reason is because the BNP is secreted through the kidneys, and as we age, the renal function is compromised. And it was clearly shown that patients with heart failure have a higher level of BNP. Not only that, but the more severe the disease, the higher the level. So there was a dose effect. And this study was done in Anand at VA hospital in Minneapolis. And he showed that patients with BNP, with higher BNP, who in the 4th quartile, have poor survival. So the higher the BNP, the poorer the survival. And this was also a wonderful study that he did. So basically, what is it? So when the BNP levels are elevated, if they remain elevated, then you have a very high morbidity and mortality. On the other hand, if the BNP levels were increased in heart failure and you treat it appropriately, bring it down, you can bring the mortality and morbidity lower. So that was an important, really a breakthrough and piece of work that was done by Dr. Anand. And the message was that, that BNP should be used as we use, say, HbA1c or glucose in heart failure, that there was no numbers available. Now we have numbers to treat. So that should be, and people, one of the problem is that these patients are not treated aggressively enough with diuretics. So this is a study that we published from here from AKU. One of my colleague now, Dr. Leena Jaffrey, whom many of you would know, she was my student. I was her research supervisor for her FCPS thesis. And the study we published in the British Medical Journal of Nephrology. And basically, I'm just going to talk about that, that one of the important aspects in heart failure patients, many of these patients have compromised renal function. So if you look at the BNP cutoffs, okay, the BNP cutoffs by the manufacturer is 125, 125 if a patient is less than 70, and 450 if the patient is over 70. So 125. Now imagine that if somebody has renal failure, they will have a higher BNP, okay? And you would never attain 125. You can give the patient the diuretics, dry him to the bone, you will not achieve that limit. So the limit of those patients should be different. And I think this study was very important because it showed that there should be different target values for patients who have kidney disease. So instance, 1,500 instead of 125 should be your target limit. And BNP could be in thousands in these patients. 7,000 for stage 4 chronic kidney disease, and if a patient has stage 5 kidney disease, then 11,000. So these were some of the really important guidelines, and those have been incorporated now into the practices generally. So in summary, the risk screening or risk assessment should be done with the traditional markers, with the LDL and HDL. You should also do a CRP and homocysteine. CRP, you have, I don't have time and I'm not going to get into it, but I think now with the new recommendations of aspirin, you know, the role of CRP and the importance of it has to be further investigated, and more data is required, as, you know, to how to move forward if you're not going to give aspirin in patients who have not had for prevention of cardiac disease, who did not have an event. I've talked about myeloperoxidase. It is a great marker for plaque instability and rupture, and can be used to stratify patients who are at high risk. For necrosis, troponin I, 0-1 or 0-3 algorithms. I talked about 0 hours and 3 hours algorithm, which I think is very good and can be easily employed at our centers. BNP can be used for the diagnosis, for prognosis of the disease, for dose titration of therapy, especially for diuretics. And I've already tried, it is inversely related to estimated GFR. That is, the lower the GFR, the higher the level of, or you know, the worse the condition of the kidneys, the higher the BNP. It can assist in diagnosing heart failure and monitoring patients with heart failure if you use higher cutoffs. Thank you all.
Thank you so much, Professor Ghani. आज के टॉपिक की इम्पोर्टेंस ये बताऊं कि आज मेरा PhD में बैठा था, तो I was talking about the prevalence of heart attack in Pakistan. तो सिंपली एक डाटा जो मेरे सामने आया कि हर 2 मिनट में एक पेशेंट आता है और 1 घंटे में 697 पेशेंट आते हैं इस एक दिन के अंदर, और उसके बाद 1 साल के अंदर 2,51,220 पेशेंट आते हैं पाकिस्तान के अंदर हार्ट के, और उसमें अनफॉर्चुनेटली जो हमारी डेथ रेट है वो 20.28% है। उसके मुकाबले में अमेरिका में जो कार्डियक हार्ट अटैक और कार्डियक इंजरीज और कार्डियक डिजीज़ की प्रेवलेंस है 8,05,000 है, जबकि उसकी जो उसकी मॉर्टेलिटी रेट है वो कम है हमारे मुकाबले में 12%। तो प्रोफेसर आमिर एजाज, now you are a panelist, would you add something before I start the answer and question, because it is a very big topic. Professor Ghani today has introduced some new marker like MPO, like modified albumin, like BNP, and like other things, very useful. Can you add something, Professor Aamir Ejaz?
Yes, sir. I will take a few minutes because there is time 7:55 already.
No problem, sir.
First of all, excellent talk as usual. I enjoyed every word of talk from Professor Farooq Ghani, and thank you very much. You initially gave some compliment also. Thank you very much, Professor Mulazim, for inviting me. First of all, I want to talk about a very common problem in our medical setups of doing this troponin by POCT devices, qualitative POCT. I call it 1 line, 2 line. So very, very important message. After today's talk, all those physicians who are listening to us, especially the junior colleagues, please do not use these 1 line, 2 line. 1 line, 2 line, they are simply wastage of money. That can be a patient safety issue. You will declare them negative and they will be very much positive. Why I'm against this, why I'm talking against this qualitative POCT assays, because as Professor Farooq Ghani has told us very nicely, that my troponin is important now for the definition of MI, rise and fall of this troponin. So how will you demonstrate rise of and fall, rise and oblique or fall, just by doing qualitative test? So this is merely wastage of money. Secondly, I talked recently, I was invited at Rahman Medical Institute,
and this was the topic of my talk. And we have to do is start a crusade against it, of this misuse of tests, because it is available in on the medical stores. The next door clinic will buy this for 700 rupees and get it done, and will say patient is okay. So it should not be done like this. And now troponin defines myocardial infarction. The topic of my talk at RMI was troponin defines myocardial infarction. So troponin. Now the second question is, should we continue to with the older tests like CKMB, LD? The answer is no. We should not waste money, especially the public funds, on tests like CKMB or LD, especially for MI. And all those funds should be diverted to the quantitative assay of HS troponin done on an amino assay analyzer like Siemens, like Roche, like Abbott, and the result may be available within 1 hour. Second, my second point is regarding a way forward, a futuristic thing, and that is now the troponin assay is becoming more and more sensitive. That means analytical sensitivity is now increasing. That means the LOD is decreasing. So as Professor Farooq said, that definition of HS troponin, one of the criteria is that it should be detectable in 50% of those population which are not having MI. So that's why we are now moving towards use of troponin as a coronary risk factor, like cholesterol, like lipids. So maybe after a few years, we will be using it as a coronary risk assessment. Thank you very much. And Professor Rashid has a question.
प्रोफेसर राशिद का एक क्वेश्चन है. प्रोफेसर राशिद, बिफोर आपका एक क्वेश्चन मेरे पास नोट हुआ है कि BNP can be detected routinely in the labs. Dr. Rashid, you will ask directly this question.
सर ऐसा है कि जब फारूक गनी साहब पढ़ा रहे थे तो साथ साथ मैं आमिर एजाज साहब से अपने क्वेश्चन पूछता रहा था. उन्होंने इसका जवाब मुझे दे दिया है कि अब वो हमने वो टाइम बचा लिया है, तो उन्होंने इसका जवाब दे दिया कि ये से लैब्स में हो रहा है. मेरा एक और क्वेश्चन है.
मैंने आपको जवाब दिया था. जी बिल्कुल. जी जी
आपने भी दिया था बिल्कुल. तो मेरा दूसरा क्वेश्चन जो है फारूक गनी साहब से कि ये ट्रॉप्स आई के टेस्ट आने के बाद जो पहले टेस्ट होते थे कार्डियक मार्कर्स CBK और SGOT और LDH वगैरह, अब क्या उसकी कहीं वैल्यू कुछ बची है कि नहीं, कि दैट इज टोटली वैल्यूलेस? जरा इस पे थोड़ा कमेंट करें.
If you allow me, I answered it, but I'll repeat it again. That is, I said that CKMB, LDH, AST should not be repeated, should not be used as cardiac markers now. Maybe you may use them for other diseases. For example, LD has got some other uses. You may continue it. AST may be used for cirrhosis, but CKMB should not be used. Yes, total CK you can use for as a muscle marker. Professor Farooq Ghani can further elaborate on this. Thank you.
जी प्रोफेसर फारूक गनी.
वो म्यूटेड है.
जी मैं उसको अनम्यूट कर देता हूँ.
ये म्यूट.
हाँ वो म्यूटेड है.
Okay, so you know, Brigadier Ejaz, Aamir Ejaz has already, I think, answered it, you know, very eloquently, that there is no use of other markers besides troponin for cardiac injuries. You know, if you want to use it for some other purpose, maybe there is some use, you know, but definitely no other marker for cardiac injury besides troponin. And now nothing besides the high sensitivity troponin.
And what about troponin T?
See, troponin, you can use I or T.
Almost.
It really doesn't, you know, it really doesn't matter whether using, it is just that, you know, that I is more widely available. But, you know, when I say troponin, I've talked about troponins, and it could be I or T.
Gee, it is a confusion among the people that I and T almost you can check both. And now any other person want to ask? Professor Madam Salma Kundi, Professor Salma Kundi, President of PMA. मैडम सलमा आपका माइक म्यूट है, माइक म्यूट है मैडम। आप काजी साहब, हाँ जी मैडम को एक मिनट मैडम, इसका अनम्यूट।
सब अब अपने आप को अनम्यूट कर सकते हैं।
नहीं जी, उस वक्त मेरा ये वो हो गया था, कुछ मसला हो गया था, I couldn't unmute myself. Anyway, it's been unmuted now. It was a lovely talk, Ji Professor Saab. I really enjoyed it. And no, I've understood, I've grasped it. No questions from my side.
Dr. Nizami Saab, Professor Nizami Saab, Kaisar Saab, Kaisar Sajjad Saab.
Dr. Kaisar Sajjad is there. He is
Kaisar Sajjad and I were बगैर Kaisar Sajjad का क्वेश्चन सुने बगैर ये हम खत्म नहीं करेंगे।
Kaisar Sajjad and I were together in medical school.
I think you have to unmute Kaisar Saab because masla hai.
मैंने अनम्यूट कर दिया।
मैडम सब अनम्यूट कर सकते हैं अपने आप को, वो सिर्फ जब स्पीकर बोल रहे थे उस वक्त आपका ये ऑप्शन बंद था। नाउ एवरीबॉडी कैन
अनम्यूट कर सकते हैं आप, अनम्यूट।
नमाज पढ़ने चले गए
जी काजी साहब, निजामी साहब, डॉक्टर निजामी साहब, any person, Dr. Zishan Arif Saab, he is the representative of WHO in Pakistan and COVID. Last time he was also on Panelist, but due to some management we cannot hear. Dr. Zishan Arif Saab, can you unmute and can you let us know about your any question about it? Dr. Zishan Arif. Ji, if you do not have,
कोई नहीं पूछ रहा।
जी anybody can ask the question. जी अपना राशिद महमूद का हाथ खड़ा है। जी ब्रिगेडियर आरिफ साहब आपका भी हाथ खड़ा हुआ है। जी सर, जी अच्छा, okay. If you do not have the question, we can close this session, and I will ask Professor Salma Kundi for the vote of thanks. निजामी साहब बोल रहे हैं, निजामी साहब बोल रहे हैं, निजामी साहब।
Thank you very much, sir.
जी सर,
Thank you very much. Thank you indeed, certainly. मैं बस सिर्फ शुक्रिया अदा करना चाहूँगा। वो जाहिर है मैडम कुंदी कहेंगे कुछ सवाल आते हमारे प्रोफेसर राशिद साहब ने पूछ लिए और बाकी चीजें। एक मैं सिर्फ आपसे गुजारिश करना चाहूँगा मुलाजिम साहब के, इस वक्त हमारे यहाँ 5 डिजीजेज हैं जो कि अनफॉर्चुनेटली अंडर अटैक है हम सारी सोसाइटी। तो आई विल अप्रिशिएट कि उसको डिफरेंशिएशन की खातिर, उनकी डायग्नोसिस की खातिर, उनके इलाज की खातिर वी हैव टू लाउड एंड स्पीक अबाउट इट। तो अगर आप इसके बारे में भी करेंगे तो आई विल अप्रिशिएट। थैंक यू वेरी मच।
आप कुछ बता देना सर, भैया सर बताएं ना, आप गाइडलाइन। जी सर आप आज बोले ना सर हमारे।
नहीं सर, मैं उसके बारे में नहीं, ये तो तफसील ही है। आप जानते हैं कि अभी हमारे साथ कोलरा भी है, डेंगू भी है, कोविड-19
अगली दफा डेंगू पे आ रहे हैं, अगली दफा डेंगू पे आ रहे हैं, डेंगू पे आ रहे हैं।
साहब मैं ये बात नहीं कह रहा, मैं कह रहा हूँ कि अब इन 5 डिजीजेस के साथ के डायग्नोसिस के हवाले से जैसा कि आपने बहुत अच्छा किया एंड अप्रिशिएट कि जो सारा आपने इनिशिएटिव ये लिया, लेकिन इन 5 डिजीज को एड्रेस करने के लिए द कम्युनिटी इन अ स्टेट ऑफ कंफ्यूजन। दिस इज व्हाट आई एम सेइंग, नॉट स्पेसिफिक डिजीज। थैंक यू।
जी मैडम, वोट ऑफ थैंक्स।
See, Qazi said there's something wrong. I couldn't unmute myself. Anyway, thanks a lot, Dr. Farooq Saab. I thank you on behalf of Mulazim Saab and everybody who's present here today, and on behalf of the PMA, thank you very much. And I also thank all the participants because they've been listening, and they've always been here with us. Thank you, thank you. Thank you, PMA brothers and sisters, and thank you all the doctors attending today. It was a lovely session. Great.
Thank you so much. Thank you so much, madam.